Yeah. Dr. Bishwas has come in. Good evening, Dr. Bishwas.
Yes.
Am I audible?
Yeah, very much.
Okay.
Good
I
evening.
hope I am also audible.
No,
Okay, Dr. Bishwoods. Okay.
you have
Nice
Dr.
to meet
Luigi
you, Dr. Bishwoods.
Califano.
Yeah, nice to meet you.
Yes, same from my side.
Yo.
So we are just waiting a couple of minutes for people to come in. Is Dr. Watts on board? Is Dr. Watts? Could you put on your camera? Dr. Watts?
Dr. Watts, Dr. Watts. Ajay, Ajay. Okay. Hi.
My great thanks to the great Califano, whom I respect very much. He is one of the role models.
My honor to be with all of you. It is for us afternoon, for you evening, late evening, I think. My honor to be with you.
Good evening, Dr. Chetna. Could you honor us by putting on your video? Dr. Chetna?
Hello.
Hi.
Hi, am I seen?
Oh, you're seen. You light up the screen like always.
Always a pleasure to be
Always
on
a
the
pleasure.
Vertigo
So,
grounds.
Dr. Chetna, Dr. Bishwas, she practices in Goa.
And of course, hello, sir. Anirban, sir.
Yes,
Hi.
sir. Yes, Chetna. So nice to see you.
Nice to see you, sir. Long time.
Yeah, very, very long time.
We're waiting for more people to join in.
No, I think we have almost reached
22, sir.
the tipping point. So I think we could commence this Vertigo grand round. It's got a grand title, but we are hoping to make it a regular feature as it has been till now. But we're hoping to continue the conversational aspect of it, the learning, teaching aspect of it, which is a very interactive session. And we are honored to have with us Dr. Anirban Bishwas, who is seriously one of the earliest and most respected and loved teachers in this field. Now, we have Dr. Anusha with us, who has a case which she will share. And then, based on that case, let's have some discussions and see how deeper we can delve into it or share our experiences in the management. It will be led by Dr. Bishwas. So, Dr. Anusha, please. Now, Dr. Anusha is an ENT surgeon who works with us in the Disease Clinic in Bangalore. Very sincere, very methodical, very hardworking. So over to you, Anusha. Please present your case.
Thank you, sir. Thank you so much. I'm very glad to have this opportunity to talk in front of all seniors in Vertigo field. So today I wanted to present a case of anterior canal BPPV. So I'm going into the presentation, sir.
Yes, please.
So, anterior canal BPPV is considered as the rarest variety of the all BPPVs. So it was first described in 1987 by Dr. Katsarkas in his article describing various positional nystagmus, varieties of positional nystagmus. Its rarity and its low incidence can be explained by the anatomical factors like it is situated superior to all other structures of the vestibular system, like all other semicircular canals and also utricle, making it difficult to migrate the otoliths anti-gravity way. And also again in supine position, it is directly descending into the crus commune, making it enable to self-clearance of the anterior canal if at all any otoliths are entered into it. So because of these anatomical factors, it has low incidence, and because of that, the studies regarding anterior canal BPPV also were very low, less in number. So coming after the anatomy orientation of the an anterior canal and also normal physiology of anterior canal, we'll briefly discuss about it. This is the orientation of semicircular canals in a diagrammatic way from in the axial plane, looking from above. So this is anterior side and this is posterior side. This is right and left. So here we can see horizontal canals in right horizontal canal and left horizontal canal having ampullary ends at the anterior end, and also right posterior canal having ampullary end here, posterior side, and also anterior canal here, making like anterior canal and posterior canal making approximately 45 degrees to sagittal plane. So anterior canal has its an ampullary end in the anterior most part. So as we all know, from the Evol's law, ampullofugal movement of the endolymph will excites the vertical canals. So if we see the normal function of anterior canal, so semicircular canals will produce eye movements through the VOR connections, vestibulo-ocular reflex connections. So we can see the here the product of VOR from the anterior canal excitation. So this movement, nodding of head, pitching forward, will have the ampullofugal movement of endolymph in the anterior canal. So it is producing upward deviation and also mild torsional effect towards the opposite side. So if we are seeing again, this is left side anterior canal excitation producing upward deviation and also mild torsional effect towards the opposite side. So this is normal function of the anterior canal. So, and if the anterior canal excites, it will produce upward deviation and opposite torsional effect. So if at all, if the excitation of anterior canal is coming from any other pathological factors like BPPV, so the slow component will be towards the upward and also opposite torsional component will be there. And the brain will make the fast correction of it, producing the fast with saccades towards downwards and same side torsional component. So this we can see in the anterior canal BPPV as down, predominantly down beating and torsional component towards the same side, because we will name the nystagmus depending on the fast component, which is the correction by the brain. So this is a brief discussion about the normal function, normal physiology. And coming, we'll move into the case presentation of today's case. We are having a 67-year-old male patient with history of giddiness from 2 years. He is complaining like constant unsteadiness 24/7 and along with that recurrent episodes of severe spinning.
Dr. Divya, please mute. Yeah, go on. Go on.
Yeah. On top of it, recurrent episodes of severe spinning sensation accompanied by sweating and apprehension, which are triggered by bending forward and looking up, lying down, which is lasting for few seconds. So because of this, he was very frightened and he is assuming that his neck movements are making him more discomfort and making him to get this vertigo, and he is completely avoiding his neck movements, and it is affecting his quality of life also. And he has in these 2 years, he has consulted many neurologists and also ENT specialists, and brain imaging was done, which was normal. And also ENT specialist has done Epley's maneuver earlier, which has no improvement afterwards. So here on examination, all oculomotor tests were normal. There is no spontaneous nystagmus, and on high frequency head shake, there is very minimal mild right beating nystagmus is there. And remaining coming to positive positional tests, which is on pitching forward and backward, there is, and also Dixalpike test on both sides, there is very minimal downbeating nystagmus with right horizontal component, torsional component, so which is very minimal. This is on Dixalpike on both sides, which is similar on both sides. But nystagmus is very minimal, but he is having subjective feeling of vertigo more on Dixalpike test. So afterwards, coming to supine straight head extension test, which is most sensitive test for anterior canalolithiasis. This is just demonstration of supine straight head extension test. So in this, we'll make the patient to sit straight. After 30 seconds, we'll make the head extend at least by 30 degrees to 90 degrees. We'll wait for 1 minute for nystagmus. After 1 minute, then again back to straight. So here, this is a video of patient's nystagmus, which is showing after head extension. Few seconds latency is there, and after latency, it is showing predominantly down beating with right torsional component. We can see in the graph also, here it is showing more down beating nystagmus with right horizontal component also. So it is, this case is falling under diagnostic criteria of canalolithiasis of anterior canal proposed by Bharani Society in 2015. So here we can see the mechanism of production of nystagmus by anterior canalolithiasis. So in the, on sitting position, this is upon extension of head, movement of endolymph, we can see clearly it is ampulofugal. Because of that, we are getting predominantly downward beating nystagmus. So by that we can we have diagnosed it as right anterior canalolithiasis or right anterior canal BPPV. Here, the differential diagnosis we have to keep in mind is apogeotropic variant of opposite side posterior canal BPPV, because present literature is showing that in the downbeating nystagmus, in that the more number of cases are of apogeotropic variant of opposite side posterior canal BPPV. So we have to keep in mind this variant also. In present literature in 2022, from Brazilian Journal of Otorhinolaryngology, this journal, in this authors have proposed one new maneuver. If we are having doubt regarding anterior canal BPPV or opposite side apogeotropic variant of posterior canal BPPV. So in this, they have proposed this maneuver. So first right with bending forwards and then turning towards one side, same side of nystagmus horizontal component, and then bending forwards more. So by through this cycle, again coming into first position. Through this, if it is anterior canal BPPV, it will be corrected. Or if it is apogeotropic variant of posterior canal BPPV, it will be converted into the normal typical type of posterior canal BPPV, which we can treat it by Epley's maneuver later onwards. So next differential diagnosis will be central causes for downbeating nystagmus, like cerebellar lesions and also multiple sclerosis or migraine also, vestibular migraine, which will have positional nystagmus. So for this, the treatment will be Iacovino maneuver, which was proposed by Dr. Dario Andres Iacovino in 2009. So here the demonstration of Iacovino maneuver. Same first position will be straight, sitting straight. We have to wait for 30 seconds. Second position will be straight, head extension at least 30 degrees to 90 degrees. The patient will feel dizziness and also we can observe the nystagmus. So we have to wait up to the nystagmus will fade away or the dizziness completely resolves and plus 30 seconds we have to wait. Next position will be we have to convert the chin should touch the chest. We have to wait here again for 30 seconds after the dizziness resolves or nystagmus fades away. Last position will be coming to sitting position with bending forward, the head bending forward. So here we can see the mechanism of Iacovino's maneuver. We can see the otolith movement up to the peak of the anterior canal. By this position, the chin touching the chest, we are making sure that otolith won't fall back into the anterior canal again. So again, this position, bending forward, will make sure that it won't fall into the posterior canal. So it will direct it towards the utricle only. So there can be possibility of falling into same canal or falling into other canals. So we have to do very clearly, like maintaining these positions and timings we have to do. Yeah, the patient underwent Iacovino's maneuver twice, after which the symptomatically he was improved very, very well. Thank you so much, sir.
Thank you very much, Anusha. That was very clear, and I must congratulate you. Okay.
Thank you for giving me this opportunity, sir. Thank you. Thank you,
it's
sir.
a pleasure. So, Dr. Anirban, now for your enlightening us on many aspects of this. In your personal experience, how frequently have you come across anterior BPPV?
Definitely not very frequently. It's pretty rare. And as Dr. Anusha said, that it should be not more than 5%. See, mine is a tertiary referral clinic, so I may be getting 5-7%. Actually, it is much lesser. Now, regarding these things, what Dr. Anusha said, since Dr. Ajay Watts is there, Chetna is there, and so many other people are there, I would like to ask some subtle questions. Number one is that, Anusha, why did this patient, 67-year-old patient of yours, also have unsteadiness. A anterior canal BPPV is not expected to cause any giddiness. That may be functional also, we do not know. But whether when you are showing something, we have to explain everything. So what was the cause of the unsteadiness that this patient had? Leave alone any functionally. If that is there, because the patient is getting recurrent episodes of vertigo and change of weight position, so some functional component can definitely come in. Number two is that, why did your patient have a mild right beating nystagmus during the high frequency head shake test? Because a high frequency head shake test, if the patient is having a right beating nystagmus, it would suggest the possibility of a left peripheral vestibular lesion, usually, not always, but then it would suggest that. Now, how, I don't think, at least I will not be able to explain it by the anterior canal BPPV. Why should an anterior canal BPPV patient have a head shake nystagmus over there? Now, that was not recorded, I believe, because you have not shown us the VNG recording of it. Then we could have understood how much relevant it is, and whether that right beating, that left beating nystagmus that you said, whether it was of any clinical relevance or not. Because for the nystagmus to be clinically relevant, it must have at least a speed of slow phase velocity of 4 degrees or more. Anything below that, we do not usually consider it as clinically relevant. So not all findings have clinical relevance. We'll have to see whether it is accountable by our suspected disease or not. So that is something I would like to know from the August audience over there. Say, another thing
Anusha,
that
would
the
you
nystag,
like
Can
to?
I show the VNG report, sir? That graph of
yeah,
post.
please.
Yes.
I hope others are not getting bored by this, because I am asking only, na? So
No, sir. The mic is yours.
okay,
So you
sure. Sir. I think Anusha wants to show her screen.
Yes, sir. Yes.
Yeah, then please click on share screen.
Yes, sir.
Anusha, please share screen. Take your cursor down, and a green thing will pop up.
you could try to verbally explain till that time, Anusha.
Sir, it was very minimal, sir. Head shake nystagmus. So that's why I
Yes.
thought.
Yeah. What I wanted to know is that, is it clinically relevant or not? That is
Yes, sir.
a very, very important thing. Because you see, small findings will be there here and there. But which we should take into account and which should be taken as clinically irrelevant? That is a very important decision to take when you are a clinical practitioner.
Yes.
Are you having problems sharing the screen?
Okay, I think we can proceed. Let Anusha find it out. And
Yes, sir. Yes.
got it?
So, in the meanwhile,
we
have some
meanwhile,
questions on chat. Would you like to throw it open? I leave it to you, so how you
yeah,
like to
I
conduct
think,
it.
Ravi, see,
Yes.
there are some very good questions that have come up in the chat box over here.
Go
Dr.
ahead, sir.
Anand has asked one thing, which is very relevant. Anterior canal BPPV, will it be continuous for 2 years? What is the reason for the headache? Are there other reasons like thiamine or vitamin B12 deficiency? Something very important. Another thing which is also I was wanting to ask is that the downbeat nystagmus was not very clear from the video. It was too very mild, and even in the recording of the VNG, the nystagmus beats were very, very mild, were very small. The intensity of nystagmus was very, which I agree fully with what Dr. Rajesh Kumar has put in over here. Then Dr. Rajesh Kumar has said another thing that can that be shown again? I believe that goes to Dr. Anusha. And then the other questions are that how can we establish the affected site in superior semicircular canal BPPV if the nystagmus occurs on both sides at Dick's sulfide maneuver? This I think any one of you can answer. But you see, if it is a right torsional component, then you can suggest there's a high possibility of it being the right anterior canal. And if there is a left torsional component, chances of it being a left anterior canal is more. But see, point is that we are not bothered on whether it's a right anterior canal or a left anterior canal. Because if you're doing the Iacovenous maneuver, then it is the same whether it's a right canal or a left canal. Dr. Rajesh Kumar has asked another question. That is, how did you suspect anterior canal BPPV? How in routine practice ENT surgeons can suspect it? See, to suspect it, of course, Dr. Rajesh, you will have to do the head hanging test, which Dr. Anusha has shown very, very well. And I believe if this video of Anusha can be put up for view to others, then everybody can learn what is the head hanging procedure. Showing it once does not.
No, we will provide
always.
this for access after that. You
So
could
I
view the
believe
entire
it's a
thing.
head hanging test. So Dr. Rajesh, are you clear with this, or do you have to ask anything?
You could unmute Dr. Rajesh and speak also.
Would like to get some inputs from Dr. Ajay Watts also, since he's there.
See, I have been dealing with the positional downbeat nystagmus for almost 12 years, 13 years now. The first case which I did was in year 2011 when I just did a Jacobino maneuver that used to be called deep head hanging maneuver initially. So now it is popularly Jacobino maneuver, and with one single maneuver, the patient had complete resolution. Over the time, in past 13 years, I have not seen more than 5 patients of positional downbeat nystagmus, which I think were anterior canal BPPV. I think even those patients which I treated as anterior canal BPPV were in fact the apogeotropic posterior canal BPPV of the opposite side. So one thing important is that why should the otoconal clot leave the uticular macula and go superiorly unless and until it's involved in the injury, or in some sports like yoga where you do Shirshasana or somersaults, etc., or gymnastics, etc. Secondly, if at all it has reached the anterior canal, there should be a self-clearing during sitting and other upright positions. So the Professor Califano, who is here right now in his series of 2021, has found that the apogeotropic posterior semicircular canal BPPV is 6 times more common as compared to the anterior semicircular canal BPPV. And following that, I have started seeing more patients of apogeotropic posterior semicircular canal BPPV than anterior semicircular canal BPPV. Probably the mind sees only the things which we know. So I have found this, that in the apogeotropic posterior canal BPPV, it is an inhibitory nystagmus. So it is a slow crescendo decrescendo nystagmus, which is called simulparoxysmal nystagmus. So it is not a classical fast crescendo decrescendo which builds up and then slows down. So it is a slow crescendo decrescendo nystagmus. And if it is there, which is often prolonged of more than 1 minute, it has to be the apogeotropic posterior semicircular canal BPPV. Secondly, these patients of apogeotropic posterior semicircular canal even have a vague feeling of dizziness, that is the non-positional disequilibrium, even in all positions throughout the day. So that is again a point which is going in favor of apogeotropic posterior semicircular canal BPPV. My take is this.
And what maneuver would you use, Dr. Vats?
Usually when I do evaluation for the diagnostic evaluation by the positional test, I do the Dix-Alpine test on both sides and the straight head hanging test. And during that time, I also finish doing the Yakovino maneuver. I examine the patient after 1 hour, and if the patient doesn't respond, it is for all probabilities the apogeotropic posterior semicircular canal BPPV, and the Professor Califano would elaborate it further.
Is Dr. Califano still there?
Sir, can I ask one?
Please, Anusha, go ahead.
Sir, I have read that in apogeotropic posterior canal BPPV, on sitting, it will be reversed. It
No,
can be
no.
most of the cases.
Most of the cases will not reverse. Most of the cases will not reverse. Only there was a recent article by Jisoo Kim where they reported few cases in which it reversed.
Okay.
Mostly it also doesn't reverse. There is no reversal nystagmus in anterior canal BPPV also.
Yes, sir. Yes. Thank you, sir.
Dr. Califano, are you here? If you're here, you're welcome to give your comments.
Okay. I agree what just said our friend Ajay. Apogeotropic canal BPPV, in my experience, is much more common than anterior canal. You can say why? How can you differentiate the two forms? But I work always trying to converge, always trying to obtain the shift into the typical posterior canal BPPV, working about head positions, about vibration, about head shaking, about movements of flexion and hyperextension of the head. And in my experience, the shift into posterior canal, typical posterior canal happens often happens this shift. So, for example, if we can suspect a left apogeotropic or a right anterior canal BPPV, if we obtain the conversion in a typical posterior canal, we get the affected side and then the affected canal, right or left. And this is what I called, what my group called the definite form of apogeotropic or anterior canal BPPV. We must, doing with this approach, we must alert our patients that we could start from a situation as Dr. Anusha just showed us, that a mild nystagmus, mild symptoms. And if we work trying to obtain the typical posterior canal BPPV, we must alert our patient that his vertigo will be stronger than the previous one. But this is a relevant point to obtain a certain diagnosis, because in this case we can exclude central disease for sure. And we also obtain the affected side and then the affected canal. Another point, sometimes to determine the side, video HIT could be useful. In my experience, video HIT is not useful in typical form of a posterior canal. But in these cases, I remember only less than 7-8% of cases in typical posterior canal BPPV, we obtained an impaired wall of the posterior canal. While in these cases, in much more cases, we can note through video HIT if the anterior canal or the posterior canal was affected. Sometimes also ocular vamps can work giving an indirect indication of the affected utricle and then of the affected site, but only in indirect way. So I think it is important to work to obtain the conversion. Then, if we don't, no problem. I use Jacobin maneuver, Anita Bandaris, and in her work of simulation demonstrated how the simplified Jacobin maneuver works better. That's to say, avoiding the second step directly from the hyperextension position to the bending forward position. In these cases, the maneuver is well working, better working than the typical Jacobino maneuver. And in this paper was also Dario was present, so no problem with his original description of the maneuver. For apogiotropic posterior canal, I use whatever maneuver for typical posterior canal, no difference.
Good. Thank you. Thank you very much. So a follow-up question to Dr. Bishwas is, how often do you have to repeat these maneuvers?
Well, pretty often. Let me get one thing clear. And what I have found is that the Jacobian maneuver is not as effective as the Epley's maneuver or the Simmons maneuver or the maneuvers that we do for the lateral canal BPPV. They are more effective than the Jacobian maneuver. Having said so, let me also add that a lot of the anterior canal BPPVs that we diagnose are actually apogiotropic posterior canal BPPVs. So maybe that is one of the reasons why Jacobian maneuver is not very effective in a lot many cases. So rather than saying that the maneuver is not very effective, let us put the blame on us also. It is also possible that we are misdiagnosing apogiotropic posterior canal BPPV as anterior canal BPPV because we are going by the downbeating nystagmus only. Maybe that I believe Professor Califano's services we are having over here, and Dr. Ajay Watts, who is the prince of BPPV in our country today. I would like to hear your
So, I mean, I suppose the
opinion
question...
on why is it not always as effective? Is it because we are misdiagnosing?
So the question would be, first, how would you know whether you're dealing with anterior or you're dealing with apogiotropic? What is the simple rule of thumb?
One, Ravi, is that in the posterior canal apogiotropic, there will be a torsional element also. So you have to have a strong eye for that torsional element that is there. And another thing which I would like to add over there is that we all have a mindset to label all these as a BPPV. Quite a few of them are actually central positional vertigo also. So that we also need to keep in mind. It has happened to me a number of times that I have diagnosed it as this. It was not going. So I've asked for an MRI. The MRI has shown that there is a small lesion in the nodulus uvula in that region. What is still worse is that quite often it happens that you have every feature of it being a central lesion, but the MRI does not confirm it. So this is
would
a
a
messy
V-hit
area.
help? Would the V-hit help in this?
I don't think. I don't think that it actually helps much. At least for anterior canal BPPV and all. Anterior canal BPPV is not a disease where the anterior canal VOR gain is low. So if the VHIT is meant to diagnose poor VOR gain of a canal, but in an anterior canal BPPV or in any BPPV, it is not the gain of the semicircular canal that is low. But had the gain been low, the canal been hyperactive, then the nystagmus would not have happened. So I don't think that doing the VHIT actually helps very much for diagnosing this. Clinical thing is the best, I believe. And
Yes.
what Dr. Anusha has shown today is explicitly shown and analyzed. That is the only thing I think the best diagnostic tool that we have.
So,
Because
Dr. Watts,
I believe we are talking too much and depriving ourselves of learning from Dr. Califano.
No, so I'll just come in stages to him. Dr. Watts, what do you feel would be the way to differentiate an anterior canal from an apogeotropic posterior?
In my last talk on this session, I talked about VHIT. There is a study from India in which they included all patients with typical posterior canal BPPV, and they found that VHIT was normal in all patients. However, the Andrea Castellucci from Italy have found the VHIT useful in many patients with peripheral positional downbeat nystagmus. Why? Normally, the non-ampullary portion of the posterior semicircular canal is such a place where the otoconia should either fall back to the posterior semicircular canal in the periampullary region or fall forward into the utricular macula and thus making a spontaneous Q. But this doesn't happen. So there has to be a canal jam near the crust commune. It could be a physiological jam, that is a large clot size, or it could be because of the narrow tract. So in any condition, that canal could be demonstrated to have a low VOR gain. And this actually has been demonstrated in that study by Andrea Castellucci. Because Andrea is from the same place where the Luigi comes, I would hand over the proceedings to Luigi. The second thing is the response to the treatment. The Luigi's classification of grade, definite, probable, and possible is based on the response to the treatment. If the maneuvers, whatever you choose, the QLR is by Luigi, the demi-Semont maneuver and the other, the 45-degree force prolonged positioning are by the other authors of his country. If there is no response by 5 QLR done, it is almost you have to reconsider your diagnosis and you have to get a MRI brain done with dedicated cuts of the posterior fossa and probably craniovertebral junction also. So I have seen only 2 or 3 patients of apogeotropic posterior semicircular canal BPPV that did not respond to quick liberatory maneuver, which I prefer most. And instead of 5, I get it 5 maneuvers over 3 sessions. I total 15 maneuvers. If 15 maneuvers are not working, I leave that patient for other things like brain drop exercises and that 45 degrees FPP for 1 hour, because for 8 hours as it is suggested by the Vanuki is not practically feasible, because you have to keep the lateral recumbent with nose down 45 degrees in the position of the Goffoni position 2. So that is the thing. The response to treatment is the cornerstone of diagnosis of apogeotropic posterior semicircular canal BPPV. And the same applies to the Jacobino maneuver. A single Jacobino maneuver should clear the canal. And the type of nystagmus, which is different in the apogeotropic, because it is an inhibitory nystagmus, and in the anterior canal BPPV, the very few cases which I have seen is definitely a typical crescendo decrescendo nystagmus of downbeat type. That's my take.
Dr. Luigi, do you want to add anything?
Nothing to add to what I just said. I agree. I fully agree with him. Certainly not else to add.
So
the description of my tooth is perfect.
I think they have learned from the master. But here's the next question.
Sorry, not for polemic, but the paper that Anush reported to Guido Cochea, in that paper, our ideas were misunderstood. So about that paper, I had to write a letter to the editor to clarify my ideas and what wrote in 2013 or 2014, I don't remember, about the classification that Ajay just cited about definite, probable, or possible. And in that paper by Guy Corochea and Nicolas Perez, our paper was really misunderstood. So I read, if you want to read our original paper, not what others reported in a wrong way. Sorry for this for this polemic.
That's understandable. So here's the question: in all the cases which you all have seen, however rare, was there any cause, or were they all idiopathic?
These cases were idiopathic or post-traumatic.
Yeah, or did you
Yeah,
have
but
trauma or some
sincerely,
other
no,
cause?
not great difference. Sometimes, sometimes the duration of the disease is longer, but not specifically differences in the ethopathogenetic pathway. Exactly as the other case. Post-traumatic usually are typical forms, perhaps because many otoconia fall down, and we can observe in lateral canal or posterior canal a typical scenario of BPPV. Apogeotropic perhaps is the long duration. Sometimes sometimes we can actually consider some anomalies of the canal. I observed 3-4 patients with relapses during the years, not frequent relapses, but relapses during the years, always in the same way. In these cases, I could think there is actually a stenosis or some other thing in the canal, but we are not able to demonstrate this, only clinical impression, of course. But these cases were all solved by the positioning maneuver, quick liberator rotation, or Semon or Apley. No difference in my experience. All work well with repeating them many times than in the typical forms. This is real, except from the residual, the residual in which, for example, Ivanucci maneuver for apogeotropic posterior canal works very well, cleaning the canal, the posterior canal, through the common cruise of course, and we solved quickly the disease and the problem of our patient. But I repeat, my approach is a bit different. It could seem looks like strange. We apparently work to worsen the state of the patient, but apparently worsening his state, we often solve quickly, more quickly his problem through the conversion in a typical posterior canal BPPV. Another thing, perhaps, and one of the first observation by Dr. Bis was on the side, or some other, I do not remember, on the side of the anterior canal. Yes, this is a real issue. Sometimes we are not able, without video HIT, and not even if video HIT works, we are not able to determine the affected side, right or left. Torsional components are not ever evident, so sometimes we must work with a neutral side maneuver, such as Iagovino. But if torsional component clockwise for right canal, counterclockwise for right canal, clockwise for left canal is evident, we can use side maneuver, such as Vanucci maneuver, for example, that is a sort of reverse Semon from the position nose down on the affected side Semon against towards the opposite side in the final position, which is nose up and not nose down, as in the Semon for the posterior canal. So we have some useful maneuver also for cases in which the side is determined also in anterior canal.
And
But
do you
I think
use
we can solve all of them. If we are not able, then let's think to something else, MRI or cerebellar study, antibodies, anticerebellar, and so on. Very rare cases, but they do exist. We have also to remember this a downbeat. I sometimes I prefer to call these cases as the downbeat positional nystagmus, not anterior canal or apogiotropic canal. This diagnosis is at the end of our work, not at the beginning. When we observe a downbeat nystagmus, in the last years we consider then a red flag. Now I think we consider then an orange flag, but not a white flag. This is my opinion.
Okay, fair enough. So, just a small question: do you use vibratory devices to help?
Yeah, I use all when needed. All that I have head shaking, repeated my vibration, right mastoid, left mastoid, both mastoid, extreme hyperextension, yet when possible, of course, and quick movements, bending forward and leaning backwards. All that we can to mobilize autoconia. I think this is the real problem, and by vibration to reduce, to disperse them in the canal, and so they it becomes more simple to treat them, to clean the canal. All that we have is useful.
Because in India, I don't know many people using vibratory devices. What do you think, Dr. Bishwas?
What? Again?
Vibratory devices.
Vibration.
Oh. See, I have got a vibrator, and only when I find that everything is failing and I cannot save my face in front of the patient, then I apply a vibrator. But I do not have much reliance on the vibrator, how much it actually helps. See, if you are sure that this is a case of canal jam, then I believe we have a scientific reason of using the vibrator. Otherwise, most BPPVs do not require a vibrator. But then we have a 100 hertz and a 50 hertz vibrator, which we use. And if you have a very good 64 hertz tuning for, that also serves the purpose very, very well.
Really?
For that, so you do not need to buy a very high-end vibrator also.
Okay. Dr. Vats?
Just one thing,
Sorry.
Dr. Ravi, I would like to ask Dr. California there, Dr. Ajay is also, see, there are some publications which say that in anterior canal BPPV, they get very good results with the brander of exercises only. Now, how much reliable is that? See, you're all experienced people, so I would like, because a brander of exercise is something which you can tell the patient to do, and it's a very easy thing. So sometimes if you are stuck with this, we can ask the patient to do the brander off. But how effective is the brander off exercise in either anterior canal BPPV or in agiotropic posterior canal BPPV?
Yeah, I agree. Brander off is still useful when other maneuvers don't work. Together, Andrea Castellucci, we are working about a modified brander off maneuver for to be used in canal jam of the lateral canal or in jam of the posterior or the anterior canal. 2 weeks ago, I observed an incredible case of anterior canal BPPV. I get a video I recorded a video and I called it the explosion of a gem. It's really incredible. I never saw before this a case such it during this bascule movement, as we are calling this approach. Suddenly an explosive nystagmus, and then the liberation, the immediate liberation of the patients, and it was immediately time to free. Really, the name explosion of a gem, I think, was appropriate to this case. Yes, I agree. Repetitive movements such as Brand arrow can be useful in these cases. In some of these cases, when the other maneuver do not work.
Dr. Watts, your finger was raised. You wanted to make a point?
I have two things to tell. I use a very high-end Hitachi Magic Band vibrator, but only I have tried in cases with the posterior cupular lithosis. Unfortunately, in none of the patients in which I tried, it was helpful. It did not cure the condition. It did not reduce the condition. It did not convert it into the geotropic variant, or it did not free the particles from the utricular side of the cupula. Number one. Number two, in one of my patients around 5 years back, I tried in the apogeotropic horizontal canal BPPV. But in that, I also tried the head shaking with 30 degree of anteflexion of the neck. And one of the methods which was used by the Daniel Newty around in 1994, that they will suddenly turn the head from say right side to the left side, and then slowly return it back. So that I tried in that patient, and ultimately I was able to convert that patient into the geotropic variant. So it was a case of the canal side cupular lithosis, which I had converted. I had given full videos in one of my papers, which was published around 4 years back. So that is the only thing which I have been able to do with the vibrator, and a very high-end vibrator.
What do you mean by high end? Is it the frequency or the intensity?
It is the frequency. It has 5,000 hertz vibrator. That I put it here in the mastoid suprameatal region, and then I give it for 15 seconds. Then I stop. It has also got 6,000 RPM also. So that you give, if you give it for a long time, that machine will become count off. So you have to give for 15 seconds, then stop, then again give for 15 seconds. I gave 3 or 4 times, but I have been successful only once in the horizontal canal cupular lithosis and in none of the others. Secondly, if you permit me, I have a very interesting video of bilateral apogeotropic posterior semicircular canal BPPV of 3 minutes only, and would like to have the comments of Luigi in this. You will have to remove this screen.
Vishnu, can you help there? Just make him.
Yes, sir.
Just make Dr. Watts, give him access.
My screen sharing is disabled right now.
It's enabled, sir. You can share your screen.
This is a young lady which I had seen why I'm not able to play this. I just wonder.
I think you could describe it verbally and then we'll attempt a summation. We can have another VGR only on this.
This is a patient which developed apogeotropic posterior semicircular canal BPPV. Few months back, around it was in December, I treated with quick liberatory maneuver. This time around 15 days back, she came again, and now she had a nystagmus, downbeating, left torsional in left disc sulci, meaning that the right-sided apogeotropic posterior semicircular canal BPPV, and right torsional in the right disc sulci position, causing the implying that left-sided apogeotropic posterior semicircular canal BPPV. So what to do? Day one, I did manual for one side, quick liberatory manual. Then day two, I did for the other side. I repeated this for 4 days, 15 times here, 15 times here. But this didn't work any. So ultimately, I was left only with the thing that I said that you do the brand error of exercises daily, and I advocated her the 45-degree force prolonged positioning on one side on one day, on other side on one day, and it has been 20 days. She will come to me after another 10 days. Let's see what happens. But that could be the natural history of any type of positional vertigo. It goes away with time. So if it has to go away with some form of intervention, it has to go away within first few days only.
Dr. Califano, if you have a comment, you could. Otherwise, we have reached the end of our time. So, Dr. Califano, any comments? We are open.
No, also because I have some difficulty to hear from Ajay during this last minute. Some problem with my screen. Now I solved it. I found also a video about a case of apogeo with a strange shift to a the leaning position. If you want, I try to share it. If you hear me, because I don't know.
You could try. Go ahead, sir. Go ahead. Give it a try. If it works, fine. Otherwise, I'll do a quick sum up and we'll wind up. So I think maybe we could return to this and have another long discussion. So I must ask, I must make a first pass attempt at summarizing that we started with a brilliant presentation on a superior semicircular canal classical case, a wide-ranging discussions on the fact that the differential...
Dr. Nair, here is the case.
Go ahead, show me.
This is only less than 3 minutes. Now you can see a very slow nystagmus, but the torsional component is very clear. It is left torsional in the left exsulpi position. So it lasted for over a minute. Then I did it on the right side. Here again you see a nystagmus which is downbeating, and here the torsional component is all the more clear. It is right torsional. The upper poles of the eyes are moved. The left eye you see is a right torsional component. So this is a idiopathic case, no history of head injury. Only history was that she had a history of a unilateral, I don't remember the site, apogeotropic nystagmus, posterior semicircular canal BPPV in December 2023, which I successfully treated by the QLR described by Califano in 3 sessions. In fact, I required 15 maneuvers. It is still present after 1 minute. now it is fading away. So it's over now.
Great. Thanks, Dr. Watts. Maybe we should come back and have one full session on these cases. I honestly never knew we could go so deep, and I must thank Dr. Anirban, Dr. Watts, Dr. Califano, and of course Dr. Anusha, because she did, I think, an exceptionally good, clear presentation of the basics to start with, and must appreciate the fact that the discussion went on from pure anterior or superior semicircular canal to the fact that the differential diagnosis is often more common than the anterior, to the fact that we should rule out centrals, to the fact that various kinds of maneuvers should be done, should be repeated, that vibration devices have a role, and that one should always repeat the test to provoke or to see that if this canal has become another canal dysfunction. So I think I must thank you all for this extremely stimulating discussion. And I think my head is nodding so much, I have almost got into a V-hit kind of a situation, and I'll be developing nystagmus soon. But I think I've been really enlightened. So thank you very much.
Bye. Bye.
Good night to all of you.
Bye, Anirban sir. Bye, Loigi.
Good night. Good night. So
Right.
thank you so much
Thank you very much.
for your grand round. Thank you.
Thank you. Thank you.
Thank you, Dr.
Thank you, Dr. Ravi. Thank you. Thank you.
Thank you, Dr. Bishwas. We need to see you on the screen. Bishwas, can we? Did we lose him?
Yeah. I
Okay, hi. So I just no.
yeah.
We need your blessings before we go. That's all.
Yes,
So.
the video is
No. Yeah, definitely. No, before ending, I
Would
think
you
we
like to
should
give
all
any summing up comments?
give us a
Ma'am is there.
round of applause for Anusha. She has presented the entire thing in a nutshell very completely and very nicely.
Thank
Yes.
you.
So all yes to her, all accolades to her.
Thank you so much.
And
Thank you very much.
maybe we have all tried to complicate the entire canal VPPV a little bit, but then what she presented was actually what everybody should know.
Yes. Definitely.
Thank you.
you. Bye.
Thank you
Bye.
very much. Good night.
Bye.
Good night to all
Bye.
of you.
Night.
Good night, all you.
Good night.
Good night. Good night.